We have a really dynamic presentation for you today. I'm very delighted that we had yesterday's weather yesterday and today's weather today. One of our guests was actually coming from Canada, so we were not sure that he was actually going to make it because of what was happening at the airport. But we're delighted that he made it. And before I begin, let me just say that in order to properly introduce our guest today, I'm going to call up my colleague, Dr. Heather Rose. Heather is our Vice President for Commercialization and Licensing. She's our resident rock star, and we are just joined by our other resident rock star, Dr. Rose Ritz. So without further ado, let me bring Heather up, and she's been working with this team for a while now, and she's better equipped to give you a preview of what you're going to hear. Thank you.
Thank you very much, Donna, who is actually the rock star in the room. I have invited this company here because of my own personal interest in the company that started in 2017 when I met a very impassioned Montel Williams, who has a relationship with the company through his own recovery from traumatic brain injury. He is a strong proponent of the company and their device, having believed it has transformed his life. It left a very lasting impression on me. They also had at the same event a healthcare worker, a nurse practitioner, who has suffered herself a very severe traumatic brain injury. She was hit by a truck while she was out riding her bike. And almost every basic aspect of her day-to-day life was impacted by her injuries she sustained. And we were all absolutely shocked when she walked out on the stage after having seen videos of her before and after. The company's also super exciting from the standpoint of innovation because they've licensed this technology from a university. So this is a story about exactly what we do. They licensed this technology in from the University of Madison, and they've been working diligently to develop it, and we've been so lucky that they're located here with us in Pennsylvania, up in Newtown. And I really do think it's an interesting device. Knowing that it's squarely outside of my area of expertise, I've invited several people today to tell me their thoughts on the device and its particular mechanism of action. So without any further ado, I'd like to introduce Jonathan from Helius Medical Technologies. He is their Chief Medical Officer, and he's going to tell you about what they do, how it works, and would love to have a great discussion afterwards.
So first of all, can you all hear me? Jolly good, excellent. And I know I'm standing in front of it right now, but I will move aside as long as I can find the plonker. Where is the, here it is. Jolly good. So the first thing you'll notice is that I've got a speech defect. Okay, I'm not from Pennsylvania, nor am I from New Jersey. I trained as a surgeon in the United Kingdom, and I came to America because we were doing minimally invasive surgery in Europe quite a bit before. And my boss, the professor at the institution where I worked, had written to me basically telling me that he was not going to support my academic advancement unless I ceased and desist from this damn fool quackery, his very words, in a letter. A few years later, he wrote to me and said, always called us by our last names, Dear Sackier. Dear Sackier, I am putting together the next edition of my esteemed tome on hepatopancreatic biliary surgery. I'd like you to contribute a chapter on laparoscopic cholecystectomy, minimally invasive cholecystectomy. I hand wrote on the letter, Dear Prof, thank you for your kind invitation. Trust this finds you well. I seem to recall that you deemed my work damnful quackery. Therefore, I think it would be inappropriate to sully your learned tome. I get back, Dear Sackier, next to the promulgation of truth, the next greatest thing a man can do is the public recantation of an error. Now write the chapter. So I've been in the States a good number of years, and of course I wrote it. It was my boss. He's in his 80s now, and he's still my boss. Actually a lovely man. But I've always been intrigued by innovation, and I've been privileged to play a role in a few innovations the first robot that was used in the operating theatre. It was called the ESOP robot, and I helped develop that. And felt like a genius when I sold my shares at $17.90. You know, they were penny stock, right? I didn't feel quite so clever when the renamed company, Intuitive, was trading at $600 a share. So sell early, sell often. This technology came about because Montel's an old friend of mine. Because I speak funny, I used to be on his show talking about medical stuff. And I was one of the first people to find out he had multiple sclerosis, which does not normally affect black men. It's a white woman's disease. But he had it, and he had it profoundly. And I watched him deteriorate. And it was him that heard about this technology. He asked me to go and have a look at it. I said, well, I know about neuromodulation a little bit. I know a little bit about neuroplasticity. I don't know what the heck these guys are doing, but I don't see any harm. The change in him was phenomenal, absolutely phenomenal. But that's an N of one, and that's not what science is based on, that's not what medicine is based on. I still consider myself a clinician. I still hold academic titles, and the promulgation of the truth, that's very, very important. So before I leap into the inevitable PowerPoint, I want to make a couple of observations. One, we are based in Newtown, Pennsylvania. That's because I got a colleague, a friend of mine, to come in and run the company because I couldn't organize an outbreak of flu in the Antarctic. It's just not my thing. But this guy is an experienced CEO, and he said, yeah, it looks really intriguing, Jonathan, but it's going to have to be in Newtown, and it's going to have to be within walking distance of where I live, because he just sold a company and he was planning on playing a lot of golf. So I moved from Charlottesville, Virginia, to Newtown. Second is, to date, we have raised $100 million. So what you're going to see is a real snapshot of about 7 years of work. Can I ask, who here is an MD or a PhD? Who here is also, keep your hands up, also a healthcare worker in another discipline? Okay, good. So we've got a mix of people. So to the MDs, PhDs, I apologize if I patronize. I don't mean to. The slides are here to show you the work's being done. For those of you who are not doctors, I will try and pitch it the right way, and I apologize if I come across as pompous. I'm English. We all come across as pompous. So the title is From Paupers to Pons, and you'll see why in a second. Legal disclaimer, have to put this up. We're a publicly traded company, and fair balance has to be elicited in everything we say. And this is not meant to encourage people to trade in stocks and shares. I will only say things that are in the public domain. And I have to also disclose that the PONS device is not cleared yet by the Food and Drug Administration. It has been cleared in Canada. It's been cleared in Russia and Uzbekistan. Clearance is underway in the United States, Europe, Australia, and the People's Republic of China. The name PONS is a double entendre. It's short for Portable Neuromodulation Stimulator, and it hits a part of the brain called the pons virolei, the bridge of virolei. So, first of all, I said I came to you from Charlottesville, so I like associations, and when I moved to Charlottesville, I read everything I could get my hands on about Thomas Jefferson, and I went to visit his home multiple times, and I loved his innovative thinking and his disruptive thinking and his focus on education and teaching at the University of Virginia, which he called his academical village and considered his greatest achievement. So just wanted a little plug for UVA because I still have an academic position there. So Helius Medical Technologies, we call ourselves a neurotech company focused on neurological wellness. And we'll talk a little bit about that. It's just a picture of the better looking members of my team. The chap on the left is our CEO, Phil Deschamps, who apologizes for not being here today. I'm also joined by Jim and Scott, who you should talk to because they know a lot more than I do. So thanks for coming, guys. So in highlights, I would say that we are a company that is adhering to all the regulatory guidelines. We define ourselves by taking a highly ethical, patient-centric approach. That sounds like gobbledygook. It isn't. Patients are at the center of everything we do. My mum died last year. She had Parkinson's disease. And at 91, before she had her first fall, she would walk 3 miles a day, to and from the supermarket. She'd always made up, always wore nice clothes, And she'd go and visit the old people in the afternoon. She'd volunteered at a local old people's home. And then her Parkinson's took her, and she had a fall. And I watched this proud and wonderful woman deteriorate. I lost a friend of mine at 42 to ALS, and Montel has MS, and I watched it really, really damage him. He's a great guy. He's a lovely, lovely man. And it caused him hideous social as well as physical issues. Another friend of mine lost her mother to Alzheimer's disease, and I watched it destroy not just her mother's relationship, but her marriage. So neurological disease takes a massive toll. Next straw poll question. Who here knows someone with a neurological condition? Yeah, enough said. We have, it's so trite to say we have a platform technology, but we truly do. No one had thought of utilizing the tongue as a way of communicating with the brain. And as a result, we own that intellectual property space, and we own a whole bunch of other ways of delivering this message to the brain, which I'm going to tell you about. The unmet need, massive unmet need. Back in the day when I was at medical school, traumatic brain injury, what? We knew a little bit about concussion. We knew about people who took a hatchet to the head. But the fact that a sports injury or just being in a car crash could damage your brain, that was not known back when I was at medical school. Now, of course, it is known, and I'm going to show you some of the numbers. We have been doing clinical trials in Canada, the United States, Russia, Australia, with great people who have no financial ties to the company. And the results we're seeing are uncannily similar, uncannily, and I can show you some of that. Some general observations. Multiple sclerosis, a condition where the wiring of the nervous system effectively loses its insulation and it causes a whole raft of problems. There are treatments available to ameliorate the symptoms and maybe slow the progression of the disease, but there is no cure. One of the major problems in any neurological disease is issues with balance and gait. Why? We use three systems basically to balance. Our eyes, it's harder to balance with your eyes closed. Our inner ear, try spinning around in a circle. Feel dizzy? Of course. And something called somatosensory or proprioception. What's that? Well, try this little trick. Everyone do this, please, humor me. Close your eyes and touch the tip of your nose with your right index finger. Now put it down and use your left index finger. Now, there's one gentleman there who's not doing it because he knows. How did you do that? You did that because your brain is constantly processing where your finger is, and it knows where your nose is. Some of us, of course, have a much bigger target to hit, so I'm golden there. So there is a drug available to help people with MS with their gait, and it works in a percentage of patients. It has side effects. Why do they take it? Small improvement in gait. Well, try this on. You've got MS, and you've also got some incontinence, right? A small increase in your ability to walk makes the difference between getting to the toilet in time and not. And to those of you who do not have incontinence, maybe that's not an issue. But if you do, it's a life changer. Stroke, either from a bleed or from an obstruction of a vessel, hits hundreds of thousands of Americans a year and kills many of them and causes massive disability. Anyone know who that is? Dudley Moore, very good. One of my favorite actors of all time. He had supranuclear palsy. Last 2 years of his life, people always thought he was drunk. And this wonderfully funny man and brilliant jazz musician became a hermit for the last couple of years of his life. And traumatic brain injury. I believe you have something, there's this team here, the Philadelphia Eagles, that I believe won some. How is it that Americans have a World Series and don't invite other countries? Drives me up the wall. And anyway, it's not football. Football is played with your feet and with a ball, okay? So the idea of using electricity to change the way the human body behaves is not new. Of course, Mary Shelley wrote about it in Frankenstein. And any of you who saw One Flew Over the Cuckoo's Nest saw a very unfair representation of electroconvulsive therapy to treat depression, which effectively changes the brain. Neuromodulation means the delivery of energy to change the nervous system. Neuroplasticity means to create a permanent change by rewiring, reordering, changing the way the nervous system works. By the way, ECT is still used today, and it's a highly effective means of treating severe depression. But then again, there's also, I don't know how well this is showing up further back, you can take an electrical pulse generator, implant it under the skin of the chest wall, lead a wire up here, cut a hole in the top of someone's head, and drop a couple of electrodes deep into the brain to treat Parkinson's disease. It can be a life changer. A very dear friend of mine, department chair at a university, we used to hike together in the Blue Ridge, and his Parkinson's was rapid and drug resistant. 6 weeks after having this device inserted, I was there when they turned it on, and Tim was back. And it was a very emotional moment. The vagal nerve stimulator, doing the same thing in the neck to treat epilepsy. I met the guy who started that company, Skip Cummings, and everyone thought that the guy was a whack job. And no, he wasn't. Patients with epilepsy had their lives changed. And many years ago, I did some work on changing the way a muscle in your thigh works and transplanting it into the perineum, your sort of undercarriage, if you will, to do an operation to treat people with fecal incontinence. That science has now advanced to the point that we do sacral nerve stimulation to treat people with fecal incontinence. So why the porpoise, or dolphin, or whale? If those mammals dive, as the water hits their head, a whole bunch of really cool things happen in their body. Anyone here scuba dive? Okay, so you know when you dive, you've got to constantly clear your ears, and if you don't, it's going to hurt like hell, and your tympanic membranes are going to go pop. Well, these animals have a venous plexus inside their ear, which expands, fills it, so their membrane doesn't pop. Additionally, their spleen contracts and squirts more blood into the circulation. Their skin goes clammy, and internal organs like liver, kidney, heart, and brain get more blood. And the blood-brain barrier, which is an important structural and functional element, changes the way it behaves. Humans have that too. It's called the diving reflex, and it's mediated by a nerve called the trigeminal, so called because it's got 3 branches. The reflex can be shown if you take a little baby, someone else's probably, and just splash a little bit of cold water on their face, they'll go, their arms will fold in, their skin will go clammy, and if you could ultrasound them, you'd see that their spleen contracts. It goes away at about 6 months of age. Unless you happen to live in Indonesia, and you're brought up in a community where they teach you to free dive, the so-called sea nomads of Indonesia. These people can dive to in excess of 100 feet, and they can hold their breath for 15 minutes. Last year, April, there was a publication where a team of researchers went to Indonesia, splashed water on the face of these characters whilst ultrasounding. Lo and behold, their spleen contracts. They've retained their diving reflex. Now, why is that important? Because the trigeminal nerve that mediates this response, yes, there's a branch in the forehead, there are branches here, but there's a whole rich plexus of them in the tongue. And if you can put electrical energy into the trigeminal nerve, the theory was, what would we do? And I'm going to show you. There have been 3 experimental models. Many years ago, I was talking about experimental surgery, and I said, you know, I've done experimental surgery quite a lot, actually, and I got death threats. And one of my colleagues had his car tire slashed and covered in paint. So I'm always a little bit nervous. It wasn't me that did these experiments. Shiflett and his group in Texas induced a stroke in rats. And in 1/3 of the animals, they splashed a little bit of cold water on the forehead, didn't do anything to the animal's core temperature. But in those animals, the size of the stroke, the size of the brain destroyed by occluding the artery was reduced by 1/3. In another group, they stimulated the nerve just where we're stimulating it, not actually on the tongue, they dissected down into it. In those animals, the size of the stroke was reduced by 65%. Potentially game-changing. That work was seen by Chunyun Lee, who works with a chap who's on our scientific advisory board, Rajan Ryan, up at the Feinstein Institute at Northwell. And they did the same thing, but with a traumatic brain injury model. And they showed that in the group where you electrically stimulate the nerve, the size of damaged brain is dramatically reduced. The presence of inflammatory chemicals inside the head is dramatically reduced. The way that blood flows into the head is dramatically reduced. And that was also published. Chunyan, who is a very, very feisty, tiny little Chinese lady, absolutely brilliant, her attitude to this was, well, if we're preserving blood flow to the brain and the essential organs, what would happen in a model of shock? What would happen if we mimicked what happens in shock, such as you've been shot or hit by a car? You've lost a massive amount of blood. Lo and behold, if you stimulate the trigeminal nerve, these animals out-survived and had far less damage to their internal organs. We are now collaborating with the Feinstein on a whole range of other technologies that we're developing. This work was supported by the Department of Defense. So I've already mentioned the trigeminal nerve. The other important element to what we do is we don't just deliver an electrical energy and hope something lovely happens. We re-educate the patient with physical and or cognitive therapy. Everyone here learned to walk. We were all walking by the time we were 15, 16 months old, right? The right side of our body is controlled by the left side of our brain and vice versa. And if you look at a map of what the human brain looks like and what part controls what, it's pretty similar, but it's not exactly the same because he's taller than me. You have a different shaped pelvis to me. You learn to walk on a different surface. Your parents had a different attitude to the way you walk. So we all walk slightly differently. And then you lose the ability to walk as a result of a neurological disease or illness, and you try to relearn, and you try to do physical therapy. Physical therapy helps, but nothing happens to imprint the circuit, if you will. What we do is deliver the neuromodulation stimulus into the tongue in conjunction with physical therapy to re-educate. This is what the device looks like. I actually have one here, and maybe, Jim, we can pass it around. It fits around the neck, like so that you can do your exercises. It has a screen with a whole bunch of information, and this will be displayed on a smartphone eventually as well. And this electrode sits on your tongue and delivers a specially patterned group of stimuli. It looks very simple, but if you open this bad boy up, there's a lot of gubbins in there. So maybe we can pass it around, Jim, and people can have a wee look at it. The device is a smart device. It monitors your utilization. You can't just put it on the dog. We would know. We have mapped out what the waveforms look like when you're doing balance exercises or gait exercises or so on and so forth. And it will speak to the cloud and deliver utilization data. Again, the purpose of these slides, I'm not going to go over them laboriously. It's for the benefit of my medical colleagues. I can provide references and papers. We've probably got about 14 or 15 publications currently in various stages of publication, but there's been a bunch already published. 2 were in multiple sclerosis. 2 separate trials, 2 separate places, exactly the same results. And in this one, we used as a control a device that looked exactly the same but didn't do anything. So it was just something in the mouth. And what we saw was a profound difference. So profound that the question of whether it's ethical to do anything again with a pure control troubles me greatly. In this trial, one of these 2 trials, we also did a series of MRIs, magnetic resonance imaging, under 2 conditions. The patient was to do a short-term memory task, identifying abstract art, or to look at gait imagery, so it's as if they're walking. So we can see which parts of the brain light up. And what we saw was a profoundly statistically significant difference. The group that had the sham stimulation, no change. The group that had the active stimulation, big change. We then took the group that hadn't had stimulation and stimulated them. And they didn't come up quite as far as the other group, but they came up substantially. And the belief is that it's better to be naive about the treatment when you do the neuromodulation. So a brief couple of words about traumatic brain injury. And by the way, if anyone decides to do a runner without PONS, because they cost thousands and thousands to manufacture, it won't bloody work. So Traumatic brain injury is a major problem. Recent data from CDC says 2.8 million Americans go to the emergency room with some degree of head injury. Some of them, of course, have severe head injuries. They've been shot or so on and so forth. Many of them is pretty mild. 2 weeks ago, one of my colleagues came in to work late. She was going through a junction and some nimnod who'd just got his driver's license blew through a stop sign and she T-boned him. She was taken to hospital where they evaluated her and sent her home and said, "You're fine." And she came to work. And I said, "What are you doing here?" She said, "Well, there's no problem." I said, "There's a problem. You were doing 40 miles an hour, then you weren't. Because something didn't show up on a CT scan doesn't mean it's there." She comes in the next day, and I'm sitting in a meeting with her. I'm still giving her dirty looks for turning up. And I'm watching her, and she's doing this sort of stuff. And she looked like she was drunk. So little bit of a medical exam, profound nystagmus. Got her to stand. This woman does yoga. She's one of these, you know. Stood her up, closed her eyes, and I said, "You're going home now." And you're in a dark room, no screens, and it's underestimated. It's underestimated. The most common symptoms after a TBI, things like headache, sleep disturbance, cognitive disability, and altered balance. Balance is really important. If you cannot balance, you cannot walk. If you cannot walk, you cannot socialize. You cannot work. And the video that I'm not showing you is of Jerry, this patient, doing what's called a dynamic gait index. It's a standardized test of gait. And, you know, the old joke, I'm a surgeon, so walking and chewing gum is a major exercise for me. She walks constantly looking down at her feet and with her arms constantly moving out to the side. Can you imagine what that would be like to have your life dominated by that level of disability? And as I say, physiotherapists do a great job addressing this with balance and gait training. What we saw in our clinical trials is that we took a group of patients who were chronic. They were at least a year out from their injuries. So if you have a TBI, many patients, 3 to 6 months, will get better. Many, probably the majority, 50, 60%. Some will not. So those patients get sent for physiotherapy. And they will make some improvement. But what tends to happen is after the physiotherapy, they'll drift back to their baseline. And we certainly saw that with our MS trial. The group of patients who had just physiotherapy and the complete sham, they got some improvement. But 3 months later, when we brought them back, they were at their baseline. Whereas the group that had the neuromodulation, no, they were better. So, doing clinical trials in traumatic brain injury, any clinical trial, actually there's an old joke, if you want to cure a disease, start a clinical trial, right? Because you've got to find the patients. We did way more than we would have to do for a Food and Drug Administration submission for what's called a 510K. It's a form of regulatory clearance. We did not have to do a multi-site, prospective, randomized, double-blind control clinical trial. But we did. We did because, number one, I want to be able to look my colleagues in the face and say, this thing works, and here are the data, and here's the justification. We spent about $15 million on one of the trials and about $8 million on the other. And the results were quite stunning. And in order to recruit 122 subjects for the first clinical trial, and by the way, we have the largest clinical trial of any neuromodulation technology for traumatic brain injury. 122 subjects, we screened 7,426 patients to get a homogeneous population. We took people who were at least a year out so that they were truly chronic and that they wouldn't be likely to make a spontaneous improvement. We demanded that they had gone through a routine of rehabilitation for their balance disorder and had been deemed to have reached a maximal medical benefit. So they were treatment resistant. The average amount of time these people had spent in physiotherapy, 8.58 months. 8.58 months. And we deemed someone to be a responder if they, and we used doesn't matter the detail, an objective measure of balance. The SOT test, I don't know if you guys are familiar with the Neurocom SOT. It's a standardized computerized form of evaluating your balance. The maximum that's ever been seen in the medical literature in traumatic brain injury using this test is a 10 to 13 point gain, right? Remember that number. I'm going to whiz ahead to that slide. 67% of patients in our clinical trial were deemed responders, which meant that they had an improvement of at least 15 points, which is higher than has been reported in the literature. In fact, 58% of the people in this clinical trial at the end of 5 weeks of therapy were in the normal range for balance. 58% of this chronic, profound, treatment-resistant group. We looked at improvements. If your balance gets better, does your gait get better? Lo and behold, yes, it does. We did see a difference in this and in something called the 6-minute walk test, which is astonishingly a test of how far you can walk in 6 minutes. What we saw with some of this stuff, there's a test called the Get Up and Go. And by the way, I was the author of the protocol with help from 30 or 40 people, much smarter and better looking than me. But I personally went through every single test that we put the patients through, including Beck depression, Beck anxiety, all these neuropsych tests, having an MRI, going through the SOT. So I personally went through every single test and know what was involved. And when I say it was a battery of tests, it was a battery. Let's move on a little bit. Right. We also, FDA had said to us, well, the primary thing with a medical device like this is safety. We want to know it's safe. And patients with traumatic brain injury suffer from chronic headaches, and they have bad balance, so they have a propensity to fall. We were going to be taking them, putting them through an active physical therapy program, and exposing them to our technology. So FDA said, we want to see if you increase the number of headaches or increase the number of falls. Lo and behold, we reduced the number of headaches statistically significantly. We reduced the number of falls statistically significantly. We also measured sleep quality in the sleep quality index, which comes from another Pennsylvania city, the Pittsburgh index we utilized, and we saw a statistically significant improvement in the quality of sleep. This is what's called a patient-reported outcome, and FDA seems to like those quite a lot. And then we looked at quality of life metrics. There's a special scale called the Quolibri, quality of life in brain-injured patients, and we showed a statistically significant improvement. Many of these patients, we're now going through the process of obtaining testimonials from people so that we can understand in a more granular fashion what this meant to people's lives. Number of patients who said, I've gone back to work. I can ride my bicycle when my wife goes out for a run. I can play with the grandchildren without fear of dropping them. It's pretty profound stuff, and it's pretty moving stuff. It makes it easy to get up in the morning. Now, I've told you that if you get physiotherapy alone, you may make an improvement, but it'll tend to wane. So FDA, and we had a discussion with FDA about this, and we said, we'd like to look into that, and we'd like to look at the velocity of improvement. So we did a separate trial where we gave people 14 weeks of therapy. Most of it is done at home. They just come in once a week to see the physiotherapist. And then after 14 weeks of therapy, we took the device away from them. Boo hiss boo. By the way, it turns off at 14 weeks so that you have to go back to your doctor, get it reprogrammed, get the data downloaded, and get a new mouthpiece, because they only last a period of time. It's like your toothbrush. And we brought them back 3 months later and restudied them to see what had happened. You remember what percentage I told you of people who were in the normal range at this first trial? Anyone? 58%. This was done at a different location, different researchers, different patients. What do you think the percentage of people who were in the normal range was at the end of the 14 weeks? 58%. And at the end of the 3-month washout, 60.1%. So we're continuing to look at ways that we can get more and more information. We are starting up a registry for when we launch commercially. I don't need to go into that, or that, or that. The other thing that we saw was the velocity of improvement. One of the first testimonials I read was from a gentleman who's a healthcare worker who said that the moment he put it in his mouth and turned it on, he stopped feeling vertigo. It went away. When he took the device out of his mouth, it came back. And over the course of 2 weeks, it gradually diminished. We now believe that we know why. In the long-term trial that we did, the 14-week study I told you about, we did sequential magnetic resonance image scans on a subset of patients. It was too expensive to do it on all. And what we showed was that the cerebellum, the part of the brain that's responsible for your balance, increased in size. And it was a substantial and statistically and obviously clinically significant group. And these data were presented at a big neurosurgical meeting in June last year and are currently awaiting publication. So in summary, in both trials, we saw dramatic improvement. And if you look at any time point, 2 weeks, 5 weeks, washout, it was the same between the trials, and it was the same between sites in the trials. So it was remarkably consistent results. I've mentioned that. So the picture there, that's Mary Galea. Mary is a professor of physiotherapy at the University of Melbourne, the Royal Melbourne Hospital. And we'd had a telephone and email correspondence. She was fascinated by this technology. And I've finally got to meet her in a trip over to Australia a few months ago. And she's not only a brilliant lady, she's an absolute delight. She did a study where she looked at people who were in the 2 to 4 weeks after having had a stroke. And these were people who had, in addition to whatever other disability they had a balance disorder. And she used an objective measure of balance called the mini-best. She then everyone was getting their regular rehabilitation as per the protocols in that institution. 50% of the patients got physiotherapy, the physiotherapy regime that we use. 50% got physiotherapy plus our device. The mini-best is a scale where I think the number is 19. If you're below 19, you're at an increased risk of a fall. At the end of the physiotherapy alone group, not one patient was above 19. At the end of the physiotherapy plus neuromodulation group, every single patient was above 19. Mary has applied for funding to do a study in 80 patients. And by the way, obviously, it was statistically significant. She also then treated one patient with spinocerebellar ataxia. And the gains this patient made were profound, and Mary published it, and she has subsequently now applied for, and I heard earlier this week, obtained funding to do a trial in conjunction with the cerebellar ataxia group in Australia. By the way, this is a group of diseases that are pretty wretched, and there's nothing available for these patients. Anyone here been to Russia? Yeah. What did you think of it?
What did I think of Russia?
Yeah.
I was there in 1999. It was still in transition between the USSR and the new Russia.
Yeah.
And I thought that the contrast, especially regarding coming from America, was pretty stark.
Well, I was there recently, and I have to tell you, I thought the people were delightful. The food was amazing. The hotels were astonishing. The infrastructure, bit of an embarrassment to come back to JFK after flying through Moscow and St. Petersburg airports. And I got to visit, we have three collaborators in Russia. One is in St. Petersburg, and it's a specialist hospital for children with cerebral palsy. And there's a neurologist there, Tatiana Ignatova, who is now, she has a registry trial. It's not a randomized double-blind controlled trial. It's a registry. 220 kids who were not ambulating without aid. And in summary, I will tell you that if the kids came into the trial in a wheelchair, by the end of 2 weeks, they're walking with 2 sticks, 2 canes. If they came in with 2 canes, they're walking with 1. If they came in with 1, they're not using a cane. I went to Russia because when I first saw the data, it was like, this can't be real. And I've seen videos. And I was there, and I met a number of the kids, and I met the parents. Who, if you have kids, right, I remember playing catch with my son. There was a little boy, 5 years old. He had never walked unaided. He had profound ataxia. He was able to walk from here to there and back after 2 weeks of therapy, with a physiotherapist behind him, providing a little bit of encouragement, but he walked. Then she stood him on a foam pad against the wall, and if standing on foam is difficult, you know, if you've had a couple of martinis, I guess, and she was playing catch. This kid had never caught a ball before. So the kid is laughing, the mother's crying, the father's crying, I'm crying. I saw these children, I met these children, and she's now treated 220 kids. And that manuscript is in process. Another group in Russia that we're working with have taken patients with a specific tumor called an acoustic neuroma. It's a tumor that affects a nerve that goes to the ear, and not surprisingly, it causes hearing loss, tinnitus, ringing in your ear, balance problems, and some loss of sensation. And they started bringing people back who had surgery years ago, and then they started treating patients at the time of surgery. And the improvements, again, dramatic. This is currently in press, this manuscript. I mentioned that. We've also been studying neurologically intact normal volunteers to seeing what this device does to the brain. And we're working with the Montreal Neurologic Institute, pretty fine place, and a group out in Surrey, British Columbia. And we've demonstrated that if you do a 64-lead EEG, right, you're measuring brain waves. When you put the device in the mouth and don't turn it on, you don't see any changes. But when you turn it on, you see profound changes. And the most profound was in something called the attentional microstate. Now, I'm probably going to murder the explanation. Basically, it's the way the brain is paying attention to stuff. And it goes up really quite dramatically. Interestingly, when you take the device out the mouth, it doesn't go back down. And when the patients come back a week later, it's elevated above their baseline. And that manuscript is currently in process. We also measured what are called evoked potentials. So you hear something and your brain processes it. It's about 100 milliseconds. With the device in the mouth, that dropped to 60 milliseconds. So there's an increase in conduction speed through nerves. Whether that has any clinical significance at all, we have no idea at the moment, but we are testing that to look at the effects on cognition. We've also been spending a lot of money doing what are called PET scans, positron emission tomography, to look at how blood is flowing in the brain with this device. That work is being done by Alain Deguerre and Alain Petitot at the MNI. And literally, I just saw the data the other day. And this, again, is in neurologically intact normal volunteers. Evidence of profound change in the way blood is flowing to the brain. So we are cleared by Health Canada in the last few minutes. We're cleared by Health Canada. And a few months ago, we announced that we had formed a partnership with the company that actually owned the clinics where we did our Canadian leg of the trial. We had 2 clinics in Canada. And the guys that owned the clinics had talked to the patients who'd come through the clinical trial who were raving about this life-changing treatment. And they came to us and said, we want to be your exclusive partners in Canada. And those clinics, which were both established neurorehabilitation clinics, are now going to become solely PONS clinics. We announced that, and the phone started ringing off the hook. And those clinics are now, I believe, full. They're booking out for a year, so they are now looking to open additional clinics. I can tell you that I personally probably get a couple of hundred emails a week from people, and some of the, you know, I've got ALS, I've been told I've got a year. I've got frontal dementia. I've got Lewy body disease. I've got. Can you help? Of course, many of them we have no idea. In the United States, to do any trial on anything other than mild to moderate traumatic brain injury would require what's called an investigational device exemption, which is a massive amount of paperwork and a meeting with FDA, which we cannot do until we have our FDA clearance. That's why, one of the reasons why we're working overseas, because it's a bit easier. But we believe that the demand for this technology is going to be profound. We want to launch it in a very responsible manner. We do not just want to make it willy-nilly available. We want to team with institutions that are committed to high-quality medical care, high-touch patient care, and will commit to be involved in registries and other means of gathering further data. Because my guess is we know less than 1% about this technology at the moment, and we'll learn a lot from actually deploying it. We have already established relationships, and I'm legally allowed to tell you about 5 in the United States. Northwell Health, largest healthcare system in New York State, Ohio State University, Oregon Health Sciences University, Kessler Rehab, and Baylor. I got them right, Jim. But we have many, many more under discussion. But again, we do not want to just liberally release this. We want it to be in a controlled manner. Further development, that requires the input from smart people. And just finish with one thought. There's a chap who is the chief executive officer of something called the Rett Syndrome Foundation. Who here knows what Rett syndrome is? I'm really impressed. I had no idea, never heard of it. Neither had he until a friend of his daughter was diagnosed. It's a wretched neurological disease. Little girl is doing fine until she isn't. And it's rapidly progressive, and these children die in late teenagerhood or by the time they're 20. There is no available therapy. He writes me an impassioned email every week. When can we start a trial? When can we do this? How can we do this? If you put the patient at the center of everything you do, you will hopefully steer an ethical, moral, and right course. And there's another element to that. We're all going to be patients. So thank you very much for your attention, and I'll endeavor to answer any questions you may have.
Thank you so much for that amazing presentation. I mean, we knew it was going to be terrific. It was mind-blowing.
Thank you.
Before we go any further, I'm trying to see if is Dr. Rostami still here, our chairman of neurology? I wanted to just, I know his time is compressed, so I just wanted to, as a point of personal privilege, in case there was a comment that you'd like to make or. Yeah?
Very interesting. Thank you. Very interesting observations. But I'd like to see more controlled studies, more double-blind controlled studies, especially if it disorders like Rett syndrome, which is incurable, and give them hope for something which may not be there. So we really like to see double-blind controlled studies before going further.
Yeah, it's a great observation, and one of the reasons why we've tried to keep a low profile is for exactly that reason. You don't want to give people unreasonable hope. The problem with doing double-blind control, we've done several. Our TBI trials were they were controlled trials. But if you put this thing on, right, and you put this in your mouth, you can feel it. Well, we did that. And what we saw was subtle differences between the two frequencies. But if you're stimulating the trigeminal nerve, you're stimulating the trigeminal nerve. And we've shown in the studies, we've shown on fMRI and EEG, PET scan, the low-frequency device that we use stimulates the... Now, interestingly, again, there was a trend. $15 million. We saw trends. We saw that with the low-frequency pulse device, the changes in gray matter volume increase in the cerebellum were not as profound. It didn't reach statistical significance. If we were to do that, it's cost $100 million so far. We've got improvements in patients that have never been reported before. We've got evidence of structural change in the brain. We have patient-reported outcomes. Interestingly, didn't work in 100% of patients. And we did a whole range of univariate, multivariate regression analyses. The only factor that suggested you may not have a response, time from injury. The further out from injury you were, the lower the likelihood you'd be a responder. Your point's a great one, though. You know, we tried, in one of our MS trials, we used a device that didn't stimulate, basically had a short circuit inside, and we told the patients, you may or may not feel the stimulation. Okay, so you're doing an attempt to blind. We had all the evaluations, the dynamic gait indices. They were all done by blinded assessors. So the problem with the device is how do you do a complete sham? Yes, oh, absolutely. Yeah,
So if you do nothing, 50% of patients feel better.
yes, absolutely.
So that's what I'm
And
saying.
again, great point. We are going to do an MS trial. We have a protocol, and that protocol calls for just doing physiotherapy. You can't, you know, and if I'm reviewing for a journal, I'm going to say, yeah, but there's nothing in their mouth. So you're damned if you do, and you're damned if you
Yeah,
don't.
the other thing is, for example, cerebellar ataxia. There are 50 different causes of cerebellar ataxia,
Yes.
different diseases.
Yes, absolutely.
And they have to make sure you categorize them according to the cause. rather
Oh,
than-
it is going to be a very homogeneous population. And again, for the cerebellar ataxia trial, again, given that in TBI, if we'd have said to people, you're either going to get physiotherapy or physiotherapy plus the device, people would say, I'm not signing up for that. I've done physiotherapy. And what we're going to do for the cerebellar ataxia trial is a crossover design. Because, again, ethically, can we not offer it? And how will we get people to recruit when they've already done physiotherapy? But your point is well made and well taken. We've been struggling with that for 7 years now.
I'm going to ask my colleague Heather Rose to continue to modulate the conversation.
Thank you, Don. Thank you, Phil. I invited a pretty wide net of people here from Jefferson that do research that's pertinent to what this company does and see patients, and I'd love it if any of you have some on-point questions. Oh, yep, Rose. All right.
Thank you. It was really wonderful and very interesting. I'm not sure if you can share this or not, but just with regard to those individuals who got physical therapy and used the device, what was the protocol for the device? Was it the whole time they were in therapy? Was it an hour? Was it 2 hours? I'm not
Great
sure if you
question.
can share that.
Oh, no, absolutely. It's in the public domain. Very homogeneous exercise program, which consists of balance exercises done in 20-minute increments, morning and afternoon, 20 minutes of gait exercise, and 20 minutes of breathing and awareness training, meditation, if you will. Morning, afternoon, and then another session of just breathing and awareness in the evenings. They would come into the clinic for 5 days, then go home for just outpatient for 5 days for 2 consecutive weeks. Then they'd do the exercise at home, and they'd come in to see the physical therapist once a week, who would download the data and moderate their exercise. So, in fact, we even went as far as standardizing the script that the therapist would use with the patients. And so let's say they were walking 2 miles an hour on the treadmill at a 0.5% incline. The next week, they may be up to 2.5 miles an hour. And that was all notated. And we actually have neglected to mention, we did the clinical trials in collaboration with the United States Armed Forces. They provided funding and a number of other assets. And we also did a validation exercise. So we developed a physiotherapy training program that was validated by the US Army. We spent $9 million developing that program because we really want your co-professionals to buy into it. And I can tell you that's probably one of the most heartwarming things. When we were doing the clinical trial, I literally would fly down to Orlando, up to Wisconsin, across to Portland, Oregon, up to Vancouver. I was literally flying around for 2 years. And the therapists love this because their patients they're seeing profound improvements in these patients. So I think you and me will have a conversation.
Thank you. Excellent talk. So speaking of what you just said, so you have, as you're getting more data, more randomized controlled trials, more indications of use, et cetera, and therapists seeing benefits in the patients, what's your strategy from the company to kind of get it into the clinic in a sustainable way, seeing that certain kinds of FES for stroke rehab have been around for many years, yet innovating it has been quite a challenge. And so I'm just curious, have you thought about where your CPT goals are going to be? Who's going to be prescribing this? How's it going to be self-sustaining? Because my concern is that, there have been lots of sort of one-hit wonders along the years. It sounds like the company is obviously looking at it long-term and has raised a ton, but I'm just curious how you're tackling that.
Great set of questions, and there's plenty to keep me and my colleagues up at night. It's not sustainable to keep raising money We have to start generating money, or it goes away. And we're not going to let it go away. We call ourselves the purple unicorns because, boy, we've had some challenges. But the intention I can speak about, there's certain things I hope you'll understand I can't say. I can tell you that in Canada, we have met with the disability insurers. We have met with the workers' comp type insurers. We have met with representatives of the Canadian Armed Forces. We know what we need to do to get it into the Canadian Armed Forces and to get it reimbursed. We know what we need to do to get Health Canada to pay for it. But until such time, it will be a cash pay business. But we've been involved with our partners in setting up a foundation because we don't want this just to be a treatment for the wealthy. So we're setting up a foundation to provide support for those who cannot pay for it. And we're exploring similar things in the United States and around the world. What else did you ask? About CPT? Yeah, we first met with CMS. Yeah, thank you very much. It's always struck me it should be CMMS, Center for Medicare and Medicaid Services, but they went the cheaper route. We first met with them 3 years ago, and they'll basically won't look at it until we have FDA clearance, but we're making sure we're educating them. We have met with all the major insurers in the United States, met with all the major healthcare systems, and we think, look, I remember the early days of laparoscopic cholecystectomy. In fact, I was summoned to go and meet with Donna Shalala, who was then secretary, and was not well pleased because she said, you realize a lot of people who've been living with gallbladder disease are going to come out the hills to have this operation. I said, yeah, and that means that they won't get impacted common bile duct stones or pancreatitis or, Lord forbid, die. They didn't pay for it. They didn't pay for it for 2 years. We did a lot of pro bono cases. And here's something that I love. My neurology colleague has left because he'd have enjoyed this maybe. When I would take my residents on rounds, I would often ask the question, are you all familiar with that?
They're neurologists. So.
Yeah, okay. You're all familiar with laparoscopic cholecystectomy, right? Minimally invasive gallbladder surgery. Instead of a bloody great big cut, little incisions, day case surgery, off you go. So I would ask my residents, who was it that authored the pivotal randomized controlled trial of laparoscopic versus open cholecystectomy? There was always one brown noser who would say, you did, sir. And my response was, nope, wasn't me, wasn't anyone, was never done. Sacral nerve stimulation, which is way more advanced now than when I was doing it, there isn't a double-blind controlled clinical trial. How would you ethically do that? There isn't one for DBS. So, anyway, did I answer all your points? But, love to talk to you more about it because we're going to need help.
More neurology colleagues?
Thank you for your talk. I was interested when you answered Dr. Rastami's question that your attempted placebo had a stimulation rate that was very low but still had some efficacy, if I understood you correctly.
Correct.
So it raises the bigger question. On the intended therapeutic dose, are you looking at a spreading electrical signal through the nervous system that's delivered by the trigeminal nerve, or is it the trigeminal nerve per se that you're targeting? Because your distal measures in PET scan, in the cerebellum, and some of the behavioral measures are not trigeminal functions.
Oh, absolutely.
So could you just address that?
Great question. I think the short and more honest answer would be, I don't know. I think that some of the measures, some of the outcome measures, depression, anxiety, functioning, are probably a result of improved mobility and improved self-confidence and have nothing to do with the neurological. They're more of a psychological benefit, I'm guessing. However, we're collaborating with a group out at Stanford who are sleep experts because why is the sleep? And the sleep isn't slightly better, it's profoundly better. His name is Guillaume Beau, Professor Guillaume Beau, who is apparently the father of sleep medicine. And he feels that there is, because we're hitting the anterior cingulate cortex, that there's an effect through that. we did see some differences between the high and low frequency devices, some of which were statistically significant. The velocity of improvement with the high frequency pulse device was faster. They got to an improvement at 2 weeks, and the low frequency lagged. In the washout period, in the longer term trial, the high frequency pulse device did better. They had a higher retention rate. The 6-minute walk test was better in the high frequency pulse device. So my guess is that we will ascertain that there may be different frequencies for different conditions, and maybe even for different patients. I was just at the North American Neuromodulation Society meeting, and there was some data presented on implants for back pain, and about 20% of patients who had benefit at 18 months stopped having benefit. So the initial response was to take the implant out, but they're now evaluating changing the frequency. That's all we changed between the two devices. The waveform was otherwise exactly the same. It was just the frequency. But short answer, don't know.
Thank you.
All right. Raghu?
Two quick questions. One is the later part of the talk, you had 18 through 54 years of age as the group age, the test group. I was wondering if you could narrow down, segregate it into 2 or 3 different age groups. Then would your results be even better, so you have a better claim from a company perspective? And did you try the VA? And the more science related is, when you tried here, you said the first one, the trigeminal, I'm not a neurologist. Then it was a 1/3 effective. And then somewhere here was 68%. I was wondering if both of those two could be combined simultaneously. Then if they are attacking through 2 different pathways, you might get almost a 98% effect.
Okay, so to answer the second first, this was a rat study. It was not done by me. It was done by Shiflett et al. From the Texas Medical Center, and they were stimulating the occipital branch of the trigeminal nerve on the forehead with a cold compress, then electrically stimulating in this area, which is close to where we stimulate. It's the same nerve, so I don't think it would make any difference. And then the first thing you asked me was about age. Age was not a factor in outcome. The only factor that impacted response was time from injury. The further out you went, the less likely you would be to have a recovery. And if you did have a recovery, it would be more likely if you'd used the high-frequency pulse device.
Thank you.
Right. I think this will be the last question, and they'll probably be here afterwards if anybody would like to have a conversation offline.
I'm curious, not neurology, I'm ophthalmology. Ophthalmologists have been looking at the tongue stimulation to form visual images since the early 2000s.
Yes.
How does your technology differ from that technology?
Yeah, great question. It came out of the same laboratory, sir. So that technology and our technology owes everything to the work of Paul Baccarita. Paul was a New York-based doctor who ended up moving to Wisconsin. His father had a stroke, and he and his brother George weren't willing to accept his disability, and they worked aggressively to rehabilitate him. And he was very interested in the whole concept of neuromodulation, and he tried all sorts of things, tried stimulating the back. I don't know if you've seen, you should pull up some of the videos on YouTube. Really, really cool. I never had the privilege of meeting Dr. Baccarita, but he fell on the tongue because very high density of nerves, right? Highest in the body. Stable environment, easy to make sure that you've got an electrode contact. It's moist. We all know that electricity and moisture. A constant pH. And it was also pleasurable. That's just one other thing. A lot of the patients report that they really like having the therapy. So one of the things we're looking at is what does this do to serotonin? So do you know Carlo Tornatore at Georgetown? He's the chairman there. He's just another person we're collaborating with. So yeah, it's the same genesis.
Excellent. Thank you so much, Phil, for taking
Thank
the
you.
time. And thank you for everybody who also came to give me your thoughts.